Next on call, doctors, surgeries,
We're just treating the part of the stomach we're going to remove.
medications, it's Issues in Internal Medicine.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
And try to take just your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. Over time, it seems that some decisions that look simple at face value become more complicated once we learn more about the factors involved. For example, taking medicine. Where's the line between just enough and too many prescriptions? And vitamins, do we really benefit from them? Which ones are actually worth taking? And there are screening procedures like mammograms where the recommendations have changed regarding how often these should be performed. And then there's the big question, when should you just say stop? Treating this disease is causing more harm than good. Well, these are just a few of the complicated issues in internal medicine that we hope to touch upon in our discussion tonight. Our doctors are going to talk fast and furious about the facts behind the controversies, and we have Dr. Steve Billion and our medical editor, Dr. Rick Holm, on hand for a great discussion during this evening's broadcast. We're unable to take your phone calls tonight, but we've got a lot of great information prepared for you. We'll bring you a story about polypharmacy and talk about issues like the real cost of obesity to health care, and honestly, what are the good parts and the bad parts of American medicine. Dr. Holm, before you introduce our guest, the title for tonight's show is Issues in Internal Medicine, Facts Behind Controversies. The patients you see are a lot like the people watching this show, a lot like me in South Dakota. We're all getting older. We've got age-related medical problems. Chronic conditions are starting to pop up. So as an internist, what are some of the issues that you'd like your patients and people like me and our viewers to be more aware of?
I think that I'd like them to realize that everything is not cut and dried. And you know, sometimes when you go to your doctor really needs you to feel comfortable and supportive of what he or she is advising. But the reality is that if you're old enough, you realize that, well, gee, what they said was the truth 10 years ago is now different. And
that's
so
hard to hear.
It's hard to accept. And so I think that the things that are obvious and clear cut, you know, when you know to take out that appendix, that's the thing to do. We always take out that appendix. But in internal medicine, there's a lot of things that are kind of controversial. And we've got a crackerjack internist here who's old enough and experienced enough to realize and to know the value of the controversies, and it's really going to be a fun show. And I want people to listen to it and realize that, and when it's all said and done, what should I do? Talk to your doctor, take the advice that she or he gives you, and go that route. Well, I'm pleased to introduce to you our guest for this evening, Dr. Steve Billion from Avera McGreevy Clinic in Sioux Falls. Dr. Billion specializes in internal medicine, like I do. He is well suited to tackle all these subjects we're going to be talking about. Thank you so much for joining us, Steve.
Thank you, Rick. And I did give up Cracker Jacks.
Did you give up Cracker Jacks?
But I do have some experience, and I'm trying to work on staying healthy as I, too, am getting older. I guess now I've become a senior medical of the medical staff in some respects. And when you first start, you think, you know, everybody that's been there before you was much older. And
that's old now.
You are. I'm the senior member at in my clinic. I've been there the longest. There's a few that are older than me, but I've been there the longest.
I guess one thing in terms of the healthcare issues, I think it's really a changing landscape. People are taking more of their own healthcare into their own hands, and that's a good thing, and becoming more responsible for their own care. And I think a big issue is preventative medicine. You know, we just really haven't been able to get off the starting block sometimes on that one in terms of helping people to try to prevent disease and how best to identify that and how best to guide them. And we as physicians can't do it all for them. We have to help guide them. And you know, obviously some of the patients that we have are more elderly or sick or have more complicated medical regimens and really do depend on us for those nitty-gritty things that we do. But there's a lot of other things that we do that's more, has a lot of variation or flexibility that we can just kind of maybe guide them and see what they want to take and go with, or see what other areas interest them.
Well, you know, let's do it. We need to take a break right now. We'll come back to it after these words.
In the United States, spending for prescription drugs was over $234 billion in 2008, which was more than double what was spent in 1999.
One of the first issues that we're going to talk about tonight is, why do the doctors want us to take so many pills? Or do they? Well, it's not that simple, and to get off to a running start on this conversation, we're going to bring you a story that we first aired a while ago. Here's an interview with the Dean of the College of Pharmacy at South Dakota State University. He talks about the important role that your pharmacist can play in helping you stay informed when you're taking multiple medications. Dennis Hedge, Dean of the SDSU College of Pharmacy, says pharmacists can come to be important members of a patient's healthcare team.
And I think one of the true values of good comprehensive pharmacy care is the fact that an individual may have many prescribers writing for a variety of different things. And if they have one pharmacist that they trust and develop a relationship with, those medications that they're getting filled can all come back through the same central pharmacies.
Along with the idea that a pharmacist plays a key role by communicating with doctors and nurses regarding adverse drug reactions, comes the concept that pharmacists today no longer spend their days behind a high, hard-to-access counter at the back of the drugstore.
We spend a lot of time visiting with our pharmacy students as they go through the curriculum so that they truly understand that our profession is one that's changing. We've went from the days where the pharmacist used to be up on a platform, back behind a little plexiglass or something like that, to where the best setting for pharmacy care is actually just like what you and I are doing right now, maybe sitting across a table, having a conversation, taking time so that you truly understand the issues with respect to your medication.
Hedge says that the pharmacists that graduate from his program are taught the concept of the pharmacy care plan.
Basically what we're talking about is ensuring that each medication that the patient is taking, there's a true reason for that medication being prescribed and being administered. Then beyond that, with respect to their care plans, they're looking for actual and potential drug interactions. They're looking for drugs that may have been prescribed to counteract an adverse drug reaction, those kinds of things, as well as doing fundamental monitoring and helping coach patients in many ways so that they know exactly what to be on the look for in case an adverse reaction may occur.
Doctors, in a perfect world, patients know exactly why we're prescribed the pills we're taking, and the doctors we see and the specialists we see and the pharmacists all know the same, what the left hand is doing and the right hand, we're talking to each other, but it isn't a perfect world, is it?
No, it is not. And I enjoyed what he said about having one pharmacist. That'd be good. It also would be good if there was one primary care doctor, one patient medical home, patient-centered medical home that had the control of the drugs. But what's happening now, they go to a specialist. That specialist always adds her or his pill. Then they sometimes send the patient.
Do you find out that I'm taking pills from a specialist?
Sometimes. And then they go to another specialist, referred by the other subspecialist. They finally come back to me. They've got 5 more drugs. What's your comment about polypharmacy, Steve?
Well, it can get complicated, and there are a lot of pitfalls, and especially when the patients are somewhat the innocent bystander in this, or the victim, because they're trying to sort it all out, and they're getting bombarded by various different sources, the doctors and the TV ads and other things that are telling them they should be taking
You like
this
the TV
drug
ads?
or another. No, I don't. I'm not very friendly towards the TV ads.
How do you feel about pharmaceutical industry and their promotions and how much money doctors get and influence they have?
It's a multi-billion-dollar industry, and I try not to let them influence me, but they are the ones that are getting the approval by the FDA of these drugs, and they're the ones that we have to work with. I think sometimes the pharmacy ads on TV or the drug ads may scare patients a little bit.
Well, yeah,
but
when they list those
but the big
side effects.
issue is compliance. And if a patient comes to me and has heard this ad and wants to take a certain pill or try it, I've already potentially won half the battle.
Because they believe in it, they're going to take the pill.
They're willing to try it, and even if they have listened to the side effects. So I don't think it's the best method, but I look at polypharmacy issue. Every time a patient comes in, I try to trim the bush. I try to just see what medicines I can take away, and oftentimes you can't, but there are sometimes where you have to step back and say, well, maybe they really don't need this antidepressant anymore. Yeah. Maybe this heart medicine isn't necessary, and so to try to prevent adverse drug reactions, to try to prevent drug interactions, which are very somewhat common, but and also can be serious. And I look at each individual patient, try to narrow it down, and then I usually try to go away with that I've taken away more than that I've added.
How many are too many, and as a patient, what? Yeah.
Well, in the nursing home, they say 9 is too many. And it's amazing how easy 9 is. 9 drugs.
How do you get 9
drugs? Well, if you're diabetic.
Give me examples.
Okay, diabetic. So you've got blood pressure, heart failure. There you pass 12. I mean, you go to the cardiologist one time. They've got some pain. They're constipated because of the pills that they're taking.
Acid suppressors to prevent the heart side effects of the arthritis pill.
Yeah.
So all of a sudden it gets piled on. I don't know if I'd say 9 is the hard and fast number.
Well, no, that's the rule that I've heard that the government or some panel has said. I think we have.
I look at myself personally. I have trouble taking a pill once a day.
Yeah.
And much less having to try to remember to juggle that many pills. So you have to look from the patient's aspect, try to make it more simplified. So I'm always trying to, if I can't take away drugs, I'll try to simplify the regimen in any way that I can.
I do
and then always try to, I personally try to use generics just about as much exclusively as I can. There's a few certain exceptions to that where some of the bioavailability of certain of the generic drugs isn't as good. And I don't think it's always as consistent as it should be. For example, maybe Synthroid is a thyroid pill, or digoxin is a heart pill. Maybe this Flomax. I've had a few patients that have come to me. So it's hard to know, but I'm always looking at opportunities to cut. Unfortunately, I'm always having to add some at some times too, because that's what we are. We're somewhat subacute toxicologists.
Yeah, that's what we are.
Subacute toxicologists. That's a big word. Tell me, clarify.
Well,
what are you talking about?
Toxicology is the poisoning from too many drugs. That's what he's talking about.
We're always on the edge of poisoning our patients, but that is not our goal. Obviously,
our goal is, and
we're trying to help them with the medicines and use them appropriately and effectively, and yet be wary of the combinations and try to do it in the way, and then to try to help them set up a schedule where they can take them. And there's tools to help that. A MediSet, or maybe it has to be the nursing staff,
or home health nursing.
Yeah,
I like the idea, however, periodically, is to take the list of drugs and say, okay, this is the most important drug. This is a little less, but it's also important. Here's prioritize. These last 3 drugs are the least important drugs. Not to say, but if you're going to be thinking about not taking some of your medicine, then they all think that, because then those would be the ones that you can, that would be just not suggesting that you would quit those, but
so you're opening the door a little bit. That's probably
they're
right,
already doing it, because
Rick, the reality is that they're not taking their medicines 100% of the time.
Well, there's something like, what are the numbers? 50% take their medicine?
I like to think it's better than that.
Yeah.
But
I'd give them
maybe it's your patient. Maybe your patients are
I'd give them a 65% compliance, and I think that would be good.
So this is really, seriously, only 65% of us listen to you and take the pills?
No.
Like you tell us?
All of them. Some of them, that's a broad number. Let's just say that many of them only take 65% of their drugs that they should be. I mean, that's a mixed number. That's a broad number.
That's a broad estimate, but especially, when they look at it, it's hard to take pills that often. They have complicated regimen, and maybe the patients are doing pretty well to get them in most of the time. Or there's cost issues.
Yeah.
Sometimes they can't afford their pills.
Well,
now, Medicare D has helped that, whereas Medicare policy came in, but they still have co-pays, they still have the donut hole,
Yeah.
they still have some stumbling blocks, and the costs are significant even with insurance.
You said you like to prescribe, or you like to encourage people to take generics. Is that a cost issue? Is that?
It's a cost issue for everybody. It's I like to save money for the patient, number one. Save money for the government, number two. I mean, that's our money. I like to save money for the insurance companies so they can thereby reduce the price of their product. I mean, I think it's appropriate. I think my last person I'm worried about is the pharmaceutical industry, but I also believe in the pharmaceutical industry. I want them to be profitable so they can develop new drugs. Look at the wonderful things that they've been able to develop in the last years that have absolutely remarkably improved quality of health care, to include antidepressants, to include acid blockers, to go on.
Generic drugs are generally a win-win situation. But the drug companies have to spend these massive amounts of money to try to get their drug approved by the FDA, and they're the ones that are bringing us samples, and samples that then we can share with the patient. So I have a little pressure on me. If I'm going to start someone on a new drug and I have a sample, I might go to my closet and give them a trade name drug that's more expensive.
But
now,
then
some of those drugs I might try
later.
to switch them to generic later, if possible. If not, there's sometimes when I can't do that, because the new drugs, the non-generic and the trade name drugs, are the most effective drugs.
I am at the point where I don't hardly use a sample closet. I mean,
See,
I just
bummed.
generally...
You're a better man than
I try not to. I mean,
I hear
occasionally.
these nice stories. Oh, the doctor gave me samples and I saved,
It's
so
not a
much money.
saving deal.
Why?
Because you end up with an expensive drug in the long run. I like to start, if you can, I'm always go generic.
But a lot of the complicated patients, there's just circumstances where you really don't have a choice, where you have to use the other drugs, or some of it they make a more sustained release where they're easier to take. So you only have a once-a-day drug that's the trade name drug versus a 4-time-a-day drug that's the generic.
Right.
And then you might have other issues with it. So
there's times to do the expensive thing. We need to have the laterality to do the right thing for our patients and not be having undue pressure. Which brings to me a question about what's just happened. The government has come out, and this is in the hospital. You're an outpatient internist. I'm a hospital and outpatient internist.
I was in the hospital for 25 years.
Yeah, so you understand this. So there's new protocols. Of course, the government comes through now saying quality. Here's how we're measuring quality. And what's more, we're going to measure quality by paying you differently if there's a problem. And what's more, we have a quality indicator now in our hospital, brand new, that says that if the surgeon takes a patient to surgery, that surgeon needs to use Lovenox, that was on the top of their list, or heparin, which is much cheaper, just as equal in the results.
What kind of,
or
what are those?
these are blood thinners.
Okay.
Or Lovenox and heparin, or heparin and a leg pump. They don't have or the choice of the surgeon. The surgeon, our surgeon's hopping mad, and I think appropriately so.
Where did this? Is this the federal government said that?
Yeah, CMS, Central
Center for
Medicare Services, and they have decided this is, and they'll pay the hospital more if the surgeon's doing this. Well, the surgeon is just, because he has the experience. He's not been happy with the results, because when he uses the thinners, he's seen the bleeding complications. He's my age. He's been around the block. He's seen the problems. He doesn't like this. He thinks that there's a time to, and there's also a time not to. And protocols should be guidelines that you can know about and consider them when it's appropriate, not a rule that pays you better if you follow their rule. What do you think of that?
I agree with that. I think it's not always black and white. I mean, a lot of the medical practice is the art of medicine. On the other hand, if we were all doing the right thing at all times, maybe we would need this type of legislative approach that's tried to guide us. And the problem is that we have had complications with a lot of
like
blood clotting and DVTs, and sometimes people get busy and they may it's phlebitis in the legs, and maybe other complications where we just kind of forget about doing some of these preventive things. So I think the intent might be good for Medicare to try to encourage physicians to do the right thing at the right time. But to try to mandate that with black and white statements or with the threat of reimbursement issues probably alienates a lot of physicians. And I try, you know, not to pay attention too much to that. You try to do the right thing at the right time, but when it affects your hospital, when it affects the reimbursement, that's a bigger issue.
Now, is this that phrase you've used, cookbook medicine, where you go through and here's the recipe?
And and if you don't follow the recipe, they won't pay you as much.
Those
recipes, I don't have a problem. I mean, I think we should push for quality. We should do everything we can do for quality. But at the same time, we need to have the laterality to know this is an individual patient. I'm not going to want to put the blood thinners on. This is a patient I'm not going to want to use the lipid-lowering drugs.
Sometimes that becomes the hassle factor, because then you can generally opt out of these regulations or these circumstances, but then you have to write that in the note and you have to document it. And it becomes a little bit of the hassle factor. And I, as a physician, felt some of those pressures and feel them, the hassle factor. And then you feel threatened, like somebody's trying to boss you around. And we are, you know, I started out as a cottage industry, and we're pretty independent people, and physicians usually don't like to have, you know, the government intervene and tell them what they have to do with their doctor-patient relationship, which we consider a sacred relationship and something that's special. So.
I've got another question about protocols before we keep going on. Now, the protocol for me, a petite female, is it the same for a 200-pound man in certain situations, or what? How?
A good protocol would consider your weight, wouldn't it?
Okay.
So all I can tell you is that a protocol should, in every case, consider every certain individual in every way.
Well, that gets pretty.
There you go.
Yeah.
You know, you look at the protocol for diabetes. The protocol was running, we will pay you more if you get their hemoglobin A1C under 7. Well, we all kind of try to get it under 7. I mean, that's a goal. We know that under 8.2, and this is the real data, we start seeing a reduction in protein in the urine. And the higher than that, the proteinuria, but it's 8.2. Well, some doctor who teaches and who doesn't practice medicine,
famous endocrinologist,
some famous endocrinologist said it's 7. So we're all going for 7, and we find that people are falling because their sugars are too low. They're having reactions, and they're dying earlier because we're driving these older people to an inappropriate lower level.
You know, 7 may not be a bad goal necessarily if you took the broad range of average patients, but there's some patients who you just can't get there with. And for one reason or another, the diabetes does what it wants to do, not what we or CMS want it to do. And sometimes you can't get there. So I think the physician then feels bad or threatened if they're penalized when they have to settle and say, hey, I can't get your hemoglobin A1C below, you know, 9.
And that doctor
that's where you're going to live.
Well, yeah, the doctor may not take that patient then. That patient may lose her or his doctor because the doctor doesn't want to take a patient who is
well, and if you're disincentivized financially to have patients that are the more difficult or hard to control patients, you may try to cherry pick your patients and stay away from that complicated group of people because they're going to take more work. And that same kind of thing would happen in a capitated system too, where you get paid a lump sum. But doctors really shouldn't be responding like that. I mean, we generally take all comers and you try to do the best job you can. But these types of protocols and things, I think, should just be that, guidelines and protocols, and maybe there can be some right incentives. But to make it all cut and dry has some potential negative.
Yeah, there's some real danger there. Yeah.
You mentioned capitated system. Now that's a different way of.
Reimbursement.
So tell us about
explain
that.
capitation reimbursement.
Well, capitation is where the physician gets paid a certain amount per month or per member per month by like the insurance company or the government to provide all the care for that patient. And it's not very common of a reimbursement system around here, but in some markets it may be.
Well, it was for a while and it went away.
It kind of fell off. And the problem was that, you know, some of the patients that were really big users of the medical system were, you know, the physicians lost out.
It's like an all-you-can-eat buffet.
It's exactly right. It's an all-you-can-eat buffet. You lose money on the big eaters, and you gain when they are little twiggy people like you.
On the other hand, I do think physicians should be held accountable to practice quality medicine. That's the issue. We want to practice quality medicine. I think most of us would join in that effort if we feel that it's valid and that it's sincere and that it has the right kind of incentives. We want to do the best thing for our patients.
Well, how do you define quality? Because sooner or later we're all going to die on you.
Well,
yeah,
I mean, and if you're taking care of the elderly, does that mean you just keep them alive no matter what, and feeding tube and the whole 9 yards? Ooh, we can go.
Quality can go, there's a lot of different things to different people, but I think, there are certain guidelines in the way that you approach patients and the way you care for them and the way you try to prevent complications. And maybe this polypharmacy is an example of an issue where, we try to limit that and we don't just let the powder keg explode with all these multiple medications. That, those are our responsibilities. And I do think, and I'm an idealist, I think that the average physician wants to do the right thing by their patients. And yes, they want to be properly reimbursed for their efforts and work, but that's, the key issue is to care for the patient and to take good care of them. And so we need to work with the government on, whether we like it or not.
The government wants to do the right thing. It's just trying to figure out how to do that.
How to do it. And sometimes when you've got administrators and accountants or other people trying to determine that, it gets a little confounding.
It's not been a good world with all this oversight. It's changed since you started medicine and me.
Okay.
Things have changed.
Things have changed.
Well, this is a good time to take a little break, and we're going to go to our next story, which is going to give us an opportunity to talk about a lot of different things, like when should surgery be considered for weight loss, and should a patient get his or her doctor to help shop around for a surgeon? Just how does our family doctor decide which specialist to send us to anyway? We'll talk about that in a minute, but first, bariatric surgeries for weight loss, including the gastric bypass and adjustable gastric band procedures, are now the second most common abdominal operations performed in the United States. The safety and outcomes of these surgeries are still a concern. A new study in the state of Michigan shows while complication rates remain low, serious complications are associated with the volume of procedures done by hospitals and by surgeons. Catherine Dolph has more in this week's JAMA report.
So we're just freeing the part of the stomach we're going to remove.
Bariatric surgery is underway at the University of Michigan Medical Center. A little over a year ago, Pam Heatley also underwent her bariatric procedure at the U of M and says it changed her life.
I can walk all day long and my feet don't hurt. My niece wants to go to an amusement park this summer, and I'm going to go with her, and I'm not just going to stand and watch her, I'll be on the rides. I just feel free. My life is mine again.
At least in the state of Michigan, bariatric surgery is now remarkably safe.
Dr. Nancy Berkmeyer from the University of Michigan and co-authors studied the outcomes of more than 15,000 bariatric surgery patients across the state of Michigan from 2006 to 2009.
Low volume hospitals and surgeons had a serious complication rate of 4% compared to 2% for high volume surgeons and hospitals.
The study appears in JAMA, Journal of the American Medical Association.
We found that there was no difference in rates of serious complications between centers of excellence and other hospitals.
The 25 hospitals and 62 surgeons involved in the study were also part of the Michigan Bariatric Surgery Collaborative, a payer-funded clinical outcomes registry.
They collect data on all of their bariatric surgery patients and meet 3 times each year to go over those data and to plan quality improvement interventions.
This study updates earlier ones that were based largely on hospital billing data, which researchers say is not very reliable when measuring surgical complications.
With our study, we now have very strong evidence that bariatric surgery outcomes are related to procedure volume and are not related to centers of excellence status.
This also gives patients food for thought when deciding on where to have the operation and who will operate.
Patients should realize that centers of excellence have met certain safety standards for bariatric hospitals, but that they are not necessarily the hospitals with the best outcomes.
Pam Heatley was in the majority with a good outcome.
It's not for everybody, but it has been a miracle for me.
Catherine Dolph, the JAMA Report.
For each obese patient, Medicare pays $95 more for an inpatient service and $608 more for prescription drugs in comparison with normal weight patients.
Thank you for joining us tonight. We're talking about issues in internal medicine, the facts behind the controversies. And here in the studio are Dr. Steve Billion and the on-call medical editor, Dr. Rick Holm. Doctors, we just saw a story about gastric bypass surgeries and the outcomes that it produces. Now, let's talk about this. Well, is it a good idea? for somebody that's got weight
let
problems?
Me put it this way, and I know Steve is supportive of every effort that we can to help people lose weight because of the epidemic, and the best way to get at them is to exercise and eat correctly. But the New England Journal of Medicine says that actually only a third of those people in the best programs will lose weight, and in 1 year, a third of those people, will have kept it off a year, and in 5 years, 0. I mean,
Really?
they all regain it. No, with weight loss efforts. You know, all of the programs. I sense that there is a significant amount of truth to that. A lot of it is, I think, that when a person gains weight and becomes heavy, it resets their osmostat. No matter what they do the rest of their life, it's all raised to that level. And if you just let them eat what they want to eat, they'll go right back to that.
Reset the what?
Their fat stat, their thermostat. They go right to that level again. I do know that there's a lot that's familial, and the genetic studies say that you look like and weigh like your biologic parents, not your adoptive parents in adoptive studies. And I also know that the surgeries do work, but
are they risky?
They're very risky, and there's huge complications. So I've said my thing.
Obesity is a big issue in our country, and I think it revolves around a lot of our habits, our behaviors, maybe our expectations, our pleasures.
Oh, we like good food, and we don't
food
like to
industry,
exercise.
the mass production of food and the way that's changed.
Kevin Weiland will say it's the government supplementing cheap food, so that the cheap food is.
Well, I'm not guilty. I go to the menu and I look on there and I'll say, well, what can I get the most food for the least amount of money that I kind of want to eat? And so you make these choices, and you kind of do it. But I think our obesity is a big issue. It relates to heart disease and arthritis and
diabetes.
Diabetes is big, and even in the younger children. I mean, it's becoming more of an issue for our youth, and so it's so important that somehow we try to get a handle on this and put the controls on it somehow. I like to say to my patients, we have Jurassic genes in a Wendy's world.
Yeah.
And the real reality is that our body wants to hold on to that fat, or to that nutrition for times of famine, and so we're not used to. Sometimes when we diet, I think our body just starts to hold on even tighter.
Oh, it does. It does.
So if there's
metabolism slows down.
If there are ways we can sometimes affect that and have more effective diets or try to change things,
well,
those are good.
Diets. Now, you gentlemen were having an interesting conversation during the break about effective diets and ones that are out there, fad diets.
I believe that probably the biggest culprit in our weight gain in our whole society are the carbohydrate excesses. The sweets, the breads, the potatoes. And if you look at the Atkins diet or the high protein diet or those kinds of things, they did a side-to-side study in the New England Journal of Medicine, showed that the people who were on the higher protein, low carbohydrate diets were happier, they lost more weight, they did better in their diet, and their cholesterols did better. They're eating more fat, but their lipids went down. Everything was better, except that after a year, they all gained it back, just like the other group.
You've had experience with some patients on a
higher fat.
And I'm not so sure there is any perfect diet. I think some people want to go for the caveman diet. They talk about this is the high protein type diet. Yeah. Maybe that's the way we came about, and maybe people want to revert back to a more primitive or
indigenous roots and berries
indigenous
type
diet,
thing.
or call it what you want. That's maybe more whole foods and not so much processed foods. And I do think the carbohydrate is, although it's the basic fuel for our engines, we need carbohydrate, yet the amount of high fructose corn syrup that gets put into everything, and all the starches and all the processed flours and processed foods can be a problem, and some people may really gain weight on that. All that being said, I think you can lose weight on a lot of different types of diets. It seems to be a simple equation: less food in, and
more exercise,
and then you'll lose weight. But it's not always that basic, and unfortunately, some people can really try to restrict their diets and then not be able to exercise, or maybe not lose. People can lose on a low-fat diet. I think people can lose on a low carbohydrate diet. I think people can maybe lose on some diets that are reasonably restricted in proteins. But all that being said, I guess I like to restrict fats because I think some of the fats, maybe my family heritage is more prone to cholesterol problems, but I do think the carbohydrates are important to restrict. And it seems that the proteins help us hold on to muscle mass and maybe have some certain advantages where when we're eating a high protein diet, we're not getting as hungry.
Yeah, no, I like the idea of suggesting to people to not snack on something that's carbohydrate because it doesn't last, but snack on something that's protein like an egg, hard-boiled egg. And I think you and I had a conversation before the camera about the value of the good old American egg. I mean, it's not an American egg.
Eggs.
The eggs.
Aren't they going to give me high cholesterol? No, they're not.
And there's no data that eggs or the yolk, which has cholesterol in it, ever raises cholesterol.
That was bad PR.
Well, I think it was.
Well, I think the egg got kind of bashed a little bit, and the egg is so good, you're going to get some cholesterol during the course of the day, unless you're maybe a total vegetarian, a vegan. And I think the egg it's a good trade-off. You're getting that amount of protein. It keeps in the refrigerator. It's inexpensive. There's a lot of good things about the egg. But the high protein diet seems to have some advantages, and recently I've had some patients that have really lost large amounts of weight working on these high protein diets that maybe start out with an Atkins-like diet and then kind of transition you to more of a diet for life that becomes more like a Mediterranean diet. Now, I'm not so sure if the Mediterranean diet is the perfect diet, but it might be a diet that's more balanced in fruits and vegetables, some fish and protein in that fact, the olive oil, maybe some of the monosaturated oils instead of a lot of the other partially hydrogenated vegetable oils and all this other stuff that we're getting. And then you try to transition into a more of that type of diet that helps you maintain it. So if you do lose 20 pounds, 40 pounds, 60 pounds, then maybe you could keep that off in a more of a diet for life and then incorporate exercise into that. That seems to be the key.
I want to transition. All of this is lost if you're not doing portion control. Because, and I think really we could eat anything, but as long as it was less of it, we'd do better.
Little plates makes a difference.
Little plates. Use the salad plates. I mean, you look at the truck stop plates just over from the 60s, 70s, 2000. They keep getting bigger. So yeah, I think portion control is big. And then if you are going to go back for seconds, maybe go back for something like the vegetables or a little small portion of the protein or something like that. Not load up on the rice and potatoes. But if you look at some of the societies, the Japanese and other ones, they eat a lot of rice and a lot of carbohydrates, and they're still thin. So some of it is genetics, and maybe we are prone in this country to have that obesity gene.
We're not exercising enough. That's the problem, and I think that there's the data says that.
Talk about exercise.
Yeah, the data says that if you're heavy and you're exercising, you live as long as you were if you were skinny and exercising.
Isn't that harder on your joints, and you're going to wear out?
I think this whole wearing out thing is baloney. I mean, you build your body around what you're doing. You don't have one cell in your body that was the same as 7 years ago. We've changed everything over. We're completely rebuilt.
So we are what we eat.
We are what we eat, and we build. And so, I mean, you've had a heart attack. I mean, the data on angioplasties and all that says they're there for chest pain, but they don't improve your longevity. The real reason that changes longevity is adding your own vessels. You get collaterals. You develop collaterals. You rebuild. You heal. Our body is always healing. We don't give it enough credit to heal. And part of what you need to do to heal is to be exercising and being active.
But unfortunately, I don't think we know a lot of the mechanisms that are involved in some of that healing, and our understanding of immunology and maybe our genetic background and traits is something that we really haven't unlocked very well. So how can I help my body heal better? How can I prevent that breakdown? And everybody's looking to try to stay healthy, or maybe not to grow old so quick.
Well,
these are interesting issues, and there may be opportunities that develop in
that osteoporosis picture. Oh, this is a person growing old, and they show the older person and turning old, and they go, oh, take the osteoporosis pill and you won't grow old. Well, that's not true. You're still going to grow old. I mean, and then die. I mean, that's the truth.
No, I know we've talked about this at length, but I want to go one more question about weight and tying back to polypharmacy. Can't you just prescribe an appetite suppressant or a stimulant or something that's going to help me manage my weight?
They don't.
No.
The only thing that really worked was fen-phen. It worked.
But-
Fen-phen. Well, and they started having valvular disease, and it wasn't. And so, ooh, that was a pill that we don't want to use, and it was
Because
gone.
I had heart. If you take that, you get heart problems.
I know
right?
of a physician that had something like 100 people that had lost, I mean, their diabetes had gone away, they've been able to function in many, many ways. They did a tremendous improvement on the fen-phen, and then it was lost. None of them had complications from the fen-phen. They all stopped the fen-phen, and they all gained the weight again. So if we're going to find a pill, which maybe there is, it will have to be a lifetime pill.
Well, and a pill might be an adjunct to other efforts like diet and exercise, but I don't think in any way it's a replacement or anyone would really expect it to be. There are still some diet pills out there. Most of them have, are short-term efforts to try to help someone get started on that. But it is also a delicate mechanism. I mean, our appetite is something so critical to our existence that you can't just go and affect that too strongly, or you're going to have even worse complications where someone might have starvation or malnutrition or other things like that. So it becomes more complicated than just taking a pill. But I'm hopeful that maybe there will be
a better pill.
ways that we can affect that, or maybe even ways where we can instruct people on diet, where we can maybe do some genetic testing on them and analyze their family heritage and analyze their diet, and then give them a prescription to go to the grocery store.
Yeah.
And here's what you get to eat, Dr. Rick. You're going to do a couple blueberries every day.
I want you to know that right now I'm using metformin even in people who are not diabetic but pre-diabetic, plus Prozac or fluoxetine, even when they're not depressed, because when you have fluoxetine and metformin together, they seem to lose weight. And they lose 20 pounds. But it's not great. It's not fen-phen. And of course, it doesn't replace what we really need to do, and that is to eat correctly and to exercise right.
Right. And I think metformin's got some potential. It's a diabetes pill that also helps you lose weight. It kind of changes our metabolism. I'm a little bit more worried about giving people an antidepressant unless I think that's part of the feature too. And but yes, a lot of the people that get obese, their metabolism kind of slows down, and maybe they get depressed too. So it becomes a vicious cycle for them that they sometimes can't work their way out of. They don't feel good enough to exercise. They don't have the energy. Their knees hurt. They're getting arthritis. And so they get into a negative cycle. And that's when a lot of times they're turning to surgery. And I can't fault that. I think there's a place for the stomach surgery, the gastric bypass, and the lap band, and other things like that.
But
yes, like they said on there, I think it probably is good to go to an experienced surgeon, and I don't know if you all have to go to the Mayo Clinic as a center of excellence to do it.
No.
But I do think it's good to investigate that, ask your physician about who you should choose as a physician, and maybe what procedure they would check. I'm not a big fan of that surgery. I think but I can understand where sometimes people want to resort to that. But if there's other things we can do, and if we had more tools, I would feel more effective to be able to help my patients and lose weight. And sometimes I feel like I don't have very many good tools in this battle.
One tool we're going to have, and we're going to challenge all the members of the ACP, all internists, and all physicians of the state, actually through the State Medical Association, the ACP, and is to prescribe doing it daily. And we'll hear more about that on this show, but it's a program that we're going to do through the State Health Department, supported by the State Medical Association and the Internal Medicine Organization, the Family Physician Organization, and in encouraging doctors to prescribe an exercise program of at least 12 blocks of walking every day, 6 days a week. You can take Sunday off. Don't you think you can do that?
I think I should take Sunday off, yeah.
Let's talk about dying. Yeah. I'm just dying to talk about
Look at Europe. I mean, they walk all over there. In a lot of other countries, we get pretty stuck in the car. And in this environment, it's hard not to get in your car, and I'm guilty of that, too.
I walk a mile a day through the winter, 20 below.
He's good. Uphill. So you're a good example.
I try.
That's good.
I'm trying to be a good. I'm not trying to be an example.
Well,
I do it because I treats my.
But it has worked for you.
It treats my.
You have been able to keep your weight now.
Yeah.
A little easier to hear it from somebody that's actually doing it. So
it
can be done.
Yes, but it's doable even when you're really busy. And so I do
think the exercise can sometimes give you back energy.
It does.
And that's what people think, oh, it's so much work, I can't do it. But if you kind of stick with it, it can give you back the energy.
That's exactly right. It does. It does. So it's how I survive.
But you wanted to talk about dying.
I want to talk about dying.
How expensive it is.
People talk about the cost of health care, that 50% or more of the health care cost in our country is that last 2 months of a person's life, and how much is wasted there, and that we don't do enough hospice care, and we have this desperate desire to do everything when we know that they're going to die. What is your sense on that?
Well, as our abilities have become more complicated in what we can do in intensive care medicine, the hospital costs have just skyrocketed. And unfortunately, with good intentions, a lot of times a physician will be trying to help their patient or try to get them through a critical illness, and it's hard to predict whether they're going to live or die. And sometimes the costs become exorbitant, and not that it's all about cost, but sometimes we haven't maybe taken the first step or the preventative step to talk to the patients more about what their wishes are. And so first of all, the biggest thing I would say is speak to your loved ones, especially those that are over 65 or whatever, and make a plan, and then designate someone as a durable power of attorney for healthcare affairs, or make out advanced directives, what they call advanced directives. And that means that you pick someone and then you talk to them about it, and you can write things down in like a living will or in other documents and kind of establish it. Now, it's impossible to write every scenario or every circumstance down on paper in a legal paper, but if you trust them and you visit with them and you explain to them what your wishes are,
they can handle it.
They can give a lot of the guidance to the physicians and your other family and the team of physicians that are going to work on you. And some patients will say, I don't want that to be done. I don't want to go, through bypass surgery. My mother said that. She said, don't ever take me to bypass surgery. It's off the map. And we all understood that, so.
Some would say there's an age when you stop doing all that intervention, and what's more, it doesn't guarantee you're by them any time.
No. It's hard for us to accept that, though, because we are living longer and living older, and we are in denial about a lot of things, including death. And death, we're afraid of dying, and maybe we don't understand, the redemptive opportunities there, whatever it may be. But it's scary, and people sometimes don't want to talk about it.
Is that because of the way we've treated it with our kids? We've got 1 minute before we get into a final thing. I mean, could we do better with our kids? I think we could do better with our kids in exercising and pushing them to play outside. And I think we could do better with them to see dying. I mean, my son, who I thought had huge experience with an opportunity, he said when he saw grandma die, it was really the first, he saw that happen. Or I didn't see it happen, but when she died, I mean, he went to 2 funerals before he was done with college.
Well,
that's all.
It used to always happen in the home, where people would die at home, and there's a certain value to die at home. But usually those are the patients that are prepared for that or understand that they may have a cancer or something like that. And I lost a friend recently who died in home hospice, and it was a long ordeal, but his family was there at his side, and it bonded them together. It was it was a tragic thing, but yet they all grew from it. And so we're going to accept death. And I think exercise, I'd say turn off the TV and shut down the video games or limit the computer and video games, and that's going to get you outside.
Get them outside. I mean, playing outside. I love what you say about hospice. How much time do we have?
Time to wrap up. Do you have any?
What are your final comments, take-home messages? You've got about 30 seconds, Steve.
Final for the whole day?
Yeah, that's it. We're done.
30 seconds of wisdom. Go.
Well, I guess I'd say maybe an important thing is to bring up some of these issues with your physician, too. This is someone that you can talk about. It's his job and his or her job and duty to visit with you about some of these issues. And if you have some concerns, list them, bring them in. It might be more than one visit, and try to talk to your family about that. And whether it be polypharmacy, whether it be your concerns about weight or other things.
So thank you so much for joining us. It's been a great pleasure.
It's been so fun. Stay tuned. We'll be right back after this break with the homespun perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
In 1981, after training and teaching in Atlanta, I returned to South Dakota, joining a multi-specialty clinic in Brookings, and I was the first board-certified internist in our group. From the start, I had trouble explaining to people what does it mean to be an internist. People would ask if that meant I was just starting and still a training, a rookie, an intern. It has always confused people. Often I'd say I'm a general practitioner that doesn't deal with kids or deliver babies. Why weren't we named something more fitting and respectful like doctor for adults? Over time, I have cared for people both in the hospital and the outpatient setting, and other internists moved to town providing for the patients in the same way. People here began to realize that an internist is one who provides not only that first contact and continuous care, but revels in unraveling challenging problems and deals with those who suffer from very complex illnesses, which often occur in the elderly. I would add that this is not better than my family physician friend's style of practice, just different and certainly complementary. Well, I suspect my story is one experienced by many other internists throughout the country, but not for those internists who have gone on for further training and have subsequently been named. Such given names have come to the cardiologist, rheumatologist, gastroenterologist, and other internists who have specialized in a more focused field. Recently, we have another of our rank newly named as hospitalist. Why is it that once an internist has a given first name, she or he drops the family or surname of internist? In light of the comprehensive and broad scope perspective provided by training for internal medicine, I believe subspecialists are likely proud being related to such a family, but have by tradition been forced to drop their last name. I think it's time to define all the internists in their multiple jobs, especially giving credit to our internal medicine training. I submit that an internist doing ambulatory care should be an outpatient internist. Those previously named hospitalists should be a hospital internist. The cardiologists should be cardiology internists. Rheumatologists should be rheumatology internists, and so on. After all, an internist is not an intern or a rookie. I would like to be called an outpatient and hospital internist. It defines the scope of what I do, and at the same time, my depth of training. It gives me a first name and a family name, too. We'll be right back.
Email your questions to us before the show and get your concerns to the front of the line. You can find out how to contact us at our website. Just remember, make sure your question is about the topic to be addressed in the upcoming show.
Coming back here.
And no wonder.
In our medical news tonight, the American Society for Radiation Oncology has published a study that reports a new benefit from taking statin drugs. Statin drugs are a type of medication commonly used to lower cholesterol. Men who took statins while receiving radiation therapy for high-risk prostate cancer were less likely to have their cancer return than men getting radiation therapy who were not taking statins. The study looked at around 1,600 men with high-risk localized prostate cancer. 23%, over 350 men, were taking statin medications when they were diagnosed and throughout their treatment. Researchers discovered that the men taking statin drugs had better long-term results at keeping their cancer at bay. 5 years after treatment, 11% of the men taking statins had had a reoccurrence of their cancer. 17% of the men not taking statins saw a cancer reoccurrence. That's 6% more. The senior author of the study said, "We have demonstrated that statin use during radiotherapy is associated with improved biochemical tumor control among high-risk patients." So the upshot of this study is that it's something you may want to talk to your doctor about if you're dealing with high-risk prostate cancer. And in other news, a study involving lab rats suggests that if a pregnant mother eats high-sugar, high-fat foods, her baby will have a preference for high-sugar, high-fat foods. This Australian study looked at two groups of pregnant and lactating rats. One group was fed standard rat chow. I know, I looked it up, it's pet food, more or less like dog chow or rabbit chow. And the other group was fed human junk food. After the baby rats were born and they were weaned, they were allowed to choose their own diets, either rat chow or junk food. and the rats whose mothers ate junk food preferred junk food. The scientists involved in this study say that it suggests that infants whose mothers eat high-fat, high-sugar foods while pregnant and nursing will have children who are destined to, or the infants will become children destined to prefer junk foods. It's food for thought. And that's all the time we have for tonight. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central, Wednesdays at 4 p.m. Central. Once more, I'd like to thank our guest, Dr. Steve Billion, and our medical editor, Dr. Rick Holm. Thanks to you for watching and being with us tonight. Have a great evening.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by On-Call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Biocommunications at South Dakota State University.